Well, hello everybody. Welcome to the latest edition of Infection Control Matters. I'm at the ICPIC conference and I've got Phil, Russo and David Weber with me. G'day, gentlemen.
G'day, Brett.
Thank you very much for inviting me.
Well, thanks so much, David, for joining us. And it's been a very interesting ICPIC conference. There's been a lot of discussion about the impact of some of the governance and government and funding changes to the US. And at the start of the conference, there was quite a bit of discussion about that. And you gave, David, a keynote address talking about some of the impacts and some of the changes that are happening in the US that have a direct impact for infection prevention and control. And everyone was quite scared after hearing your presentation. It was a bit shell-shocked. I think that was. Yeah. But we'll turn this around towards the end of the podcast about what can we do. But you able just to outline the scale of what's going on in the US as it relates to infection control?
Yeah, let me talk about sort of three broad areas. The first is grants and studies for research to improve infection prevention, particularly intervention studies. There's been a dramatic reduction in NIH grants for all sorts of work, not just infection prevention, but cancer prevention, many other things. So that will clearly, in the long run, affect the U.S. and just the world and the ability to get new information to fight infectious diseases and other diseases. Separate from that, there has been a dramatic decrease in personnel and funding for people broadly within fighting infectious diseases and more specifically infection prevention. Department of Health and Human Services and CDC both have lost about 20% of their personnel. We're talking thousands, tens of thousands of people that have been let go. CDC's lost about 20,000. They continue to lose thousands additional people. And the funding for these agencies is facing dramatic decreases in funding that may be anywhere from 20 to 50% in the near future. So that obviously will have a major impact on CDC's ability to do things. For instance, I was on a phone call with CDC, and their rabies group has been substantially reduced, as well as their lab group. They're not able now to keep up with the demand for both consultations and testing, and they have to now prioritize that. So that's just one simple example. Then next, I would say many of the advisory committees have been eliminated or dramatically changed. So HICPAC, which provided CDC with guidelines for infection prevention for decades now.
And used right across the world. You know, the HICPAC guidelines are really...
Everybody wonderful guidelines for years. I was a member of HICPAC. I was fired in February. HICPAC has been dissolved. It will no longer be making guidelines.
Anecdotally, how did you get fired? Is it as an email?
I got an email saying, thank you very much for your service on HICPAC. It's immediately terminated.
Yeah.
Very short email. That was what it said.
How back does HICPAC go, David?
HICPAC goes back at least 2 or 3 decades there. And for instance, I co-wrote the guideline on sterilization disinfection with my colleague Bill Rutella back in 2008, and I worked on it before. They have superb guidelines, all evidence-based guidelines done by experts. Now, keep in mind, HICPAC, as well as other advisory committees, like the Advisory Committee of Immunization Practices, are only advisory to the CDC director. They never made guidelines directly by themselves. They were not independent, and they were advisory to the CDC. But they provided a HICPAC a great value. Other things that HICPAC was working at the time that it was dissolved, they had completed a new isolation guideline, talking about transmission-based guidelines for everything from COVID and flu to norovirus.
And did that incorporate the new terminology around through the air?
Yes, it did.
Because that's the big practical part that has to come from those guidelines.
And that guideline has been finished, voted on, approved, needed a few modifications. I don't know if it'll ever get published. Things that most of us find great use was what's called Appendix A, which was an alphabetic list of diseases that included essentially, norovirus and rotavirus and COVID and smallpox, with what's the incubation period, when are people infectious, and recommended specific guidelines like contact, enteric precautions, droplet precautions, aerosol airborne precautions. That will, professional organizations may step up, but that will no longer be done by CDC. other things. This is at the time HICPAC I was co-chairing a group to come up with new guidelines for sterilization, disinfection of dental water lines. They've been associated, when not properly maintained, with non-tuberculous mycobacteria infections. I don't know if, again, the American Dental Association may step, but those guidelines won't see the light of day. And CDC and I was on a working group that CDC was working on developing guidelines for occupational health for healthcare personnel. Many of those have been published, but we're working on additional ones. Again, it's unclear if we'll see the ones that already been finished published, and going forward, newer ones developed. Now, there is a little bit of good news, I will say. Just this week, CDC did publish in the journal Infection Control Hospital Epidemiology the new guideline for post-exposure prophylaxis for healthcare personnel who've been exposed to HIV. So if that's something that you're interested in, and either from an infection prevention standpoint or an occupational standpoint, those guidelines are now public information in the journal.
So with your role as president of the Society of Healthcare Epidemiology of America, do you think, just thinking about those HICPAC transmission-based guidelines, for example, do you think there'll be organisations such as SHEA that, in the absence of none of that progressing, that there might be enough coalition of the willing professional groups working more collaboratively together to try and get some of these guidelines up and developed?
That will definitely happen. SHEA has already had conversations, particularly with our sister group, Association for Professionals in Infection Control, that represents about 15,000 infection prevention nurses and others in the United States, that we will begin working together to help develop guidelines and take some of the place of HICPAC. The limitations for us really are funding, and particularly we have many members. 10% of all SHEA members sit on a committee. We have the ability to do guidelines, but the limiting factor is the literature searches for the questions we ask, which is time-consuming and expensive. And the background of the guideline, of course, a guideline is only as good as the questions you ask and your review of the literature. And so there are both time and funding limitations to how quickly we can do those. But there's no question these organizations will step up to develop similar guidelines. Of course, SHEA already has multiple guidelines. We have our compendium we do every 3 years. We're already beginning work on the next iteration, and that includes things like hand hygiene, surgical site infections, bloodstream infections, et cetera. So we'll continue working on those guidelines. And of course, our sister journal, Antimicrobial Stewardship and Hospital Epidemiology, has stepped up through SHEA, working guidelines such as diagnostic stewardship. I don't know if they'll have the same impact worldwide as the CDC guidelines did, but I think that's something we can do.
I wonder, guidelines and the impact that will have on guideline development is going to be significant, acknowledging what you've just said, though. I guess when there are huge funding cuts to research in particular, then there'll be a knock-on effect of not actually having high-quality studies or less studies to help inform guidelines. Have there, and I mean, that's me assuming here that there's been big cuts in terms of research-related funding. Is that the case as well?
Yes, absolutely. The group within Health and Human Services was AHRQ that funded most of its funding went to improve healthcare quality. That's what that was designed for. The good news is they still have the funding money appropriated by the U.S. Congress. The bad news is they've let go their entire group, essentially the 200 plus people who manage that funding. I believe there are only a few people, less than 10 left. So although they have the money, they have no means to do the grants or administer the money because there's no one left. So yes, you're right. The amount of funding to support research to answer the questions going forward that improve healthcare infection prevention in the United States, worldwide, has been severely decreased. So yes, if you want evidence-based guidelines, you need ongoing evidence, and the funding for that has been substantially reduced. And I should say, of course, worldwide, the U.S. is unlikely to support things like Gavi, vaccines for children and others. It's eliminated all its funding for the WHO, which was about 15% of their total funding. So many of the things that the WHO wants to do are eliminated. The Centers for Disease Control is not allowed to have communications in general with the WHO anymore, and not allowed to have communications even outside the CDC within the United States. They've not refunded a number of the groups that were dealing with pandemics. Of course, we have potentially a pandemic coming of H5N1. It's never a question of if you're going to have another pandemic. It's only a question of when. And the U.S. is severely underprepared to deal with pandemics within the U.S. or to help other countries deal with emerging diseases that might lead to a pandemic worldwide.
I was just going to say that there was also mentioned that there's lack of support now for US employees to come to these sort of conferences and present. And we've had a couple of folk from the States here who have made a point of declaring that they're here as an independent person and not a part of an employee. Is that an accurate reflection of what we're seeing?
It's even worse than that, because even if they came as a private person, they would not be allowed to present any of their information or data that they've accumulated as a CDC or an HHS employee. So at the most recent SHEA meeting in April and in the forthcoming ID Week meeting, there are no presentations by CDC personnel of new research, new data. They were physically not allowed to come to the meetings nor really talk publicly. So this obviously will have a major effect as well. They could come, presumably as a private person, take vacation time and come, but they would not be allowed to talk about any of the data that's been generated at the CDC without explicit permission from the CDC director, and that has not been forthcoming.
Yeah.
Sorry, Phil.
You go.
I was going to say, after you gave your speech on the opening address at HICPIC, Jeremy Farrar from the World Health Organization did a very impassionate speech.
Great talk.
Fantastic talk.
Yeah.
And I just want to quote a couple of things just so that we can reflect on that for our final part of this podcast. He said, "History is made by those who stand up and fight, and this is one of those moments in history." And he went on to describe that in more detail. And he said, "We should never be reliant on one single donor. The tail of this legacy will unfortunately be seen for years." Infection control agenda every single day in every single care, not just outbreaks. We need to build trust in the system as we move forward. I guess that's almost a call to say, okay, let's fill the void. What do we need to do moving forward, acknowledging these challenges? And look, to be fair, perhaps there have been a lot of reliance on certain organizations or CDC or others for funding a lot of research and other elements. And so I guess now we have to say, well, how are we going to address that? I guess in the context of Australia, Phil, I'd like to see certainly much more research funding now in the infectious disease, public health, infection control space, because we need to step up. We need to be able to fill that gap. And things like the professional associations, which might come to them, working more closely together.
Yeah, I think so. I think the other key message I got from Jeremy Farrar's presentation was, forget about the past. We're not going to go back to what it was. It's never going to be like that again. And so we do need to come together and work together. So it will probably be up to the professional bodies to hold the mantle and work together to create those opportunities.
And perhaps government funding bodies, the ECDC, the UK HRI in the UK funding bodies, the NH and MRC in Australia and the like in Singapore, in Canada. I think there's going to be a real need for them to step up and support and prioritise some of this infectious disease, public health based research. And I was going to say just one thing before I hand to you, David, is in Australia, we're about to establish a CDC, and there has been generally to date a lack of engagement or interest in infection prevention control being part of that CDC. So we need to seize these opportunities, I think, now in the context of what's going on. What are your thoughts on the future and what we need to do?
Well, I think from first of all, professional organizations can and are stepping up. In the U.S., there are already multiple talks, and the American Medical Association has made at least $2.5 million available to develop potentially an alternative to the Advisory Committee of Immunization Practices. We've had guidelines already from the American College of Gynecology about, say, COVID vaccines for pregnant women, which they support. The American Academy of Pediatrics has already published their own list of childhood vaccines and what should be done. So the professional groups can step up and work on that. It won't have the same impact in the United States as CDC, because by law, if a CDC recommended a vaccine, it had to be covered by insurance, and it was also covered by the National Vaccine Compensation Act if you had an adverse event. That can't happen by, automatically for professional organizations, but they are stepping up. SHEA and IPPIC, as I've mentioned, will step up and write guidelines more specifically to infection prevention. We'll have conversations with the Infectious Disease Society of America about if a new disease emerges, about them filling the gap with rapid recommendations saying diagnosis and treatment. And the infection prevention groups would then provide guidelines on safety for healthcare providers, as well as isolation. So there's some things professional organizations can do. Also, I'm speaking at least for SHEA, we're trying to develop better international networks. We've signed a memorandum of understanding with the Asian Pacific Infection Control Society. We're looking to develop collaborations with other groups, including Australia, but Greece, clean hospitals here in Geneva, and develop a better international network. The one thing we can't do probably is these professional groups can help with outbreaks in other countries, with education, with guidelines. We don't have the funds to actually fund research in general, the way CDC or the National Institutes of Health did, or to support
emergency responses,
or emergency responses. We don't have the funds. We can make people available, but we don't really have the funds to, transport people and care for people in other countries. So that's really going to have to be other countries stepping up. Potentially things like the Gates Foundation and potentially other large private groups can do that. But it's really going to have to be other governments stepping up to provide that type of funding, although we can provide the expertise and the training.
It's an interesting situation, isn't it?
It is.
At the same time that CDC in the States is being dismantled, Australia is trying to, or has established a CDC, and the Association for Infection Control,
Australasia.
ICPIC, sorry,
You should know that one, Phil, yeah.
have been quite vocal in making sure that they try to get some say in the CDC in Australia as well. So I've often thought we do look to the States, what could happen in the future, and I think this is something that we need to keep this in mind, that if once the Australian CDC does get established, we need to hold on to it and keep it precious and make sure that what's happening in the States doesn't happen to us, I suppose.
I think clearly within Australia, you ideally would want to have your new CDC very involved in healthcare-associated infections. They remain a major source of morbidity and mortality worldwide. And of course, I've never met anybody who says it's okay if I go into hospital to get my hip because, I'm 50 and I injured it playing golf, wants to get an infection in that artificial hip. So there's, near uniformity that this is something we need to do. One thing I think countries could do better, if you look at the United States and other countries, they list their diseases that cause mortality in that, accidents, suicide, homicide, respiratory disease, and so on. I'm not aware anywhere in the world that they list healthcare-associated infections in their nationally published list of causes of death. In the United States, it used to be 5th or 6th. Now it's about 10th. I think people would be much more likely to want to support it if you actually saw it listed and I don't understand the reasons that we've never listed it that way.
That's an interesting
But you never see it listed as a source of disease, and out of sight, out of mind, or the old adage in the United States, the squeaky wheel gets the grease. So I think that would be one thing you could do in Australia and we should do in the United States is when we produce our yearly list of sources of mortality in the country was to list healthcare-associated infections. I think people would be much more aware of it than they are now.
Yeah.
Sorry, Phil.
I was also going to, the other thing I think we'd like to know about is that, particularly in Australia and probably a lot of other countries, look at data that comes out of NHSN as a bit of a benchmark or a comparator. So is there any issues with the NHSN moving forward? Is that will continue to generate the data that it does at the moment?
The answer is yes. NHSN was moved out from under HICPAC at the end of December. It's now separately a group in CDC. I'm not aware they've had any major of cuts in funding or personnel, so it continues to exist. And in many ways, it's expanding some of its things. They've moved their old baseline, which is 2015, to a more recent baseline that's being phased in at the moment. They've been working on a new goal, which is in general, the data that's submitted to NHSN has lots of hospital data: hospital size, hospital location, academic, not academic, cancer hospital. But outside of surgical site infections, it has limited patient level data. They're working on to automatically be able to query using artificial intelligence and machine learning individual electronic medical records, and almost virtually throughout the U.S., no one uses paper records anymore, and build a system. It'll have two advantages. It will include patient-level data, things like diabetes, obesity, immune compromise, that will allow much more accurate data on risk factors to adjust for all of those differences. And it would mean that the infection prevention nurses won't spend the time generating data to send to NHSN, or all be done automatically, and free up time of those highly trained individuals to work on implementation. That, to some extent, will require more funding. The other thing that's, and this is good for NHSN, that moving forward is, so things have gone in waves. When the old scenic study done in the United States in the 60s and 70s, which laid the foundation for infection prevention, they looked at all infections. Then for a while, we focused more on efficiency, meaning the biggest bang for the buck. So we focused on infections in the ICU, and we focused on device-related infections like central line, urinary catheter there. But with time, because we haven't focused on the non-device-related infections, the device-related infections have fallen. And look at urinary tract infections and pneumonia, at least in the United States, most infections there are not related to devices now. But we have limited data on how to adjust for those and how to alter the non-device related infections, because we did do surveillance, and that's changing. So we've moved away from ventilator-associated pneumonia to ventilator events, but we also need to thinking about the non-ventilated patients. The U.S. is going to be introducing in the next year or two, moving away from central line-associated bacteremia to monitoring all bacteremia and getting more data. And I think we need to continue that, and that is a plan of NHSN, but I think we need to do that worldwide. Yeah. And they've moved away from just looking at infections in the ICU to looking at infections throughout the hospital. And it is true, the risk is higher of a ventilator pneumonia, or let's take a bloodstream infection in the ICU than on the floor. But because we have many more patients not in the ICU, there are actually more infections that are not ICU related. So I think all of those are good things. And for some of them, they do require additional funding, but I think they will improve. The one thing that isn't happening is NHSN was under HICPAC, and you had an advisory group of people really on the front lines who have to implement this. And at the moment, NHSN, at least in the US, doesn't have a means of getting input from the clinicians, that is hospital epidemiologists, infection preventionists, who have to implement the surveillance guidelines, and do this all the time, to really give them feedback as to a new surveillance definition or a change, whether it's actually practical and feasible to implement it. And that's a concern.
Look, it's been a fascinating chat. We better leave it there. David, thank you so much for your advocacy and leadership, particularly with SHEA on these issues. And thanks for being quite open and honest and as much as you can be about what's going on and sharing those insights, because I think through being, I guess, through solidarity with other professional organisations and groups, we can get through this. So thank you very much. And of course, we'll see you in Australia in November too, for the Australasian College for Infection Prevention Control Conference in Hobart. Phil, thank you very much.
Yeah, thanks, Brett. Good to be here. Thank you, David.
Yeah. Thank you. Pleasure as always.
Thank you very much. And that's it for us for Infection Control Matters for this edition. Bye for now.